This video will demonstrate oroendotracheal intubation. The first pre-hospital care provider assists the patient's ventilations with a bag mask device. The second provider assembles and tests the orotracheal intubation equipment, which includes a selection of variously sized endotracheal tubes, a selection of variously sized blades, a malleable stylet, water-soluble lubricant, a 10 cc syringe, a suction device, and multiple-size suction catheters, a stethoscope, and end-tidal carbon dioxide monitor. The proper sized endotracheal tube, based on the patient's size, is selected. If a malleable stylet will be used to shape the endotracheal tube for ease of insertion, it is placed inside the endotracheal tube with the end of the stylet about 1/2 to 1 inch from the distal end of the endotracheal tube. Next, the distal end of the endotracheal tube is lubricated with a water-soluble lubricant. Before the intubation is attempted, the patient is hyperoxygenated with 4 to 6 ventilations to achieve an oxygen saturation rate of 100%. The provider assumes a position above the patient's head. With the laryngoscope in the left hand, the patient's airway is opened and the blade is inserted into the mouth and behind the tongue. The provider continues to insert the laryngoscope blade into the posterior pharynx. Finally, the provider lifts up and forward with the laryngoscope handle and visualizes the vocal cords. With the right hand, the provider inserts the endotracheal tube between the patient's vocal cords until the proximal end of the cuff passes through them. The markings on the endotracheal tube indicate the proper depth of insertion, which is usually 21 centimeters for the average adult female and 23 centimeters for the average adult male. The provider holds the endotracheal tube in place and removes the laryngoscope blade. The provider removes the stylet, if a stylet was used in the endotracheal tube, and then attaches the syringe and inflates the cuff with 5 to 10 milliliters of air. Next, a bag mask device is attached to the endotracheal tube along with an end-tidal carbon dioxide monitor when available. The patient is ventilated with the bag mask device. The placement of the endotracheal tube must be verified. Verification of endotracheal tube placement. Once intubation is complete, specific measures should be taken to ensure that the endotracheal tube has been properly placed in the trachea. Techniques to verify endotracheal tube placement include the use of both clinical assessments and adjunctive devices. Clinical assessments include the following: direct visualization of the endotracheal tube passing between the vocal cords, presence of bilateral breath sounds and the absence of air sounds over the epigastrium during ventilations, visualization of the patient's chest rising and falling during ventilations, fogging or water vapor condensation in the endotracheal tube on expiration. Adjunctive devices include the following: carbon dioxide or CO2 monitoring to include end-tidal CO2 monitoring or capnography and calorimetric CO2 detector, a pulse oximeter device. While each clinical assessment and adjunctive device technique has unique qualities, no technique is 100% accurate alone. 2 or more of the clinical assessment techniques should be performed, followed by the use of at least one of the adjunctive devices to ensure proper endotracheal tube placement.